Thank you. So I'm going to start off the segment on perimetry talking about the pros and cons of the visual field. Disclosures. But first I want to talk about progression. Unfortunately, anyone who sees glaucoma patients, both you and your patients are likely to experience progression during that time. As an example, I want to present this study that is from the Rochester Epidemiology Project, where they reviewed a number of patients who were newly diagnosed with open-angle glaucoma and had the benefit of a long follow-up period, and found that the rate of legal blindness at 20 years for one eye was 20%, which is somewhat shocking. And in both eyes was 9%. And those results are somewhat tempered by the fact that those rates were worse when the patient, when newly diagnosed, already had a visual field defect, and that the patients in this analysis excluded pseudoexfoliation and pigmentary. They focused on POAG, which means that those other more aggressive forms of glaucoma might also lead to higher rates of progression. I don't present these numbers as a be-all, end-all of what we should expect in terms of rates of glaucoma progression. There are other studies that are more on the other end of the spectrum and show much lower rates of progression. But as an example of something that we don't perfectly understand, but that glaucoma progression occurs, it's something that, despite our position in the developed world and all of our best efforts with medicines, technologies, and surgery, is unavoidable ultimately in the care of a glaucoma patient population. Visual field progression is itself a defining criteria for glaucoma treatment. So there's no way to prospectively study the natural course of glaucoma progression and its effect on visual fields and the rate of progression, because that would be ethically unacceptable. However, we can try to address the question of how fast do people progress from glaucoma by approaching it indirectly. So, for example, if we use retrospective data and cross-sectional studies, and we look at people who are diagnosed with early defects and people who are diagnosed at late defects, you could make the assumption, and it's certainly an assumption, that the difference in their ages may be a surrogate for their rates of progression. And so if you look at an analysis of a patient population in which this was done, patients who were untreated at first diagnosis with pressures in the low 20s, it seemed that it took about 14 years for people at that pressure range to go from early defects to late defects. In the high 20s, 6.5 years. Over 30, 3 years. So some interesting information about how fast and dangerous glaucoma progression may be, though this analysis obviously is based on assumptions. So to start off with the pros and then move on to the cons. Visual field change in glaucoma occurs in characteristic patterns, which is critically important for following for progression and differentiating glaucoma from other diseases, and also in that because it's a relatively stage-wise visual field change, you can look at a visual field and have a decent idea of what the optic nerve will probably look like and where the patient is in the course of their glaucoma progression. And although that's a point that is so elementary as to perhaps be unworthy of mention for this audience, I think that, like most rules in medicine, there are exceptions, and the exceptions on the con side are more interesting. The visual field is a non-invasive, painless, and quick way that we can measure patients' peripheral vision for progression. Now, of course, that's all relative, as anyone who's taken a visual field test knows. But as our sophistication increases with testing equipment and algorithms to analyze the data, we are doing a better job of getting reasonable results with relatively quick test times. So if you look at with the Humphrey machine, if you use a seat of FAST, which is an appropriate way to follow patients for glaucoma progression, the mean test time may be somewhere around 4 minutes an eye. And for the Octopus, which uses the tendency-oriented perimetry or TOP strategy, we can get test times in the 2 to 3 minute range. Visual fields are also the beneficiary of a long history of accruing data on glaucoma patients. And although there are advances in the algorithms and in the technology and ultimately changing machines, the bottom line is that the visual field machines, for better or worse, have changed less than some of our machines for analyzing the optic nerve, for example. So that while we've already are trending from GDX and HRT closer and closer to OCT, and to be more specific, from time domain to spectral domain OCT, By the time we have longitudinal information to really get a good evidence-based handle on how to identify progression and how to separate sensitivity from hypersensitivity by using those devices, we may already be on to the next machine. And at least with visual fields, we do have long-term analysis of a lot of data, which can provide some benefit. Also, as Dr. Spaeth was just alluding, the visual field test helps us get closer and closer to the principles that he's espoused about the importance of treating glaucoma patients, not just to lower pressure, not just even to prevent peripheral vision loss as manifest by visual field change, but actually to prevent visual disability, to prevent that loss of vision which actually affects a patient's function. And as an example, if you look at an article published by Dr. Spaeth and others here at Wills this year, looking at a number of patients who had a wide spectrum of different visual field defects, and then benchmarking them against data from the ADREV, which is an objective way to measure patients' function when they have vision loss. And if you analyze their fields using multiple grading systems, the ones in research projects that you may be familiar with, Hodapp, Parrish, Anderson, etc., you can conclude that the best predictors of functional ability and quality of life in glaucoma may in fact be the amount of binocular field loss and the status of the better eye on which the patient is functioning. And that even with all of our complex systems for analyzing field progression, something as simple to obtain as the mean deviation in the better eye may have a very direct correlation with the patient's ability to function, which is what we're trying to improve and preserve. To get at this idea with just another example of a study, fear of falling is an important metric in measuring people's health. And in fact, falls are the leading cause of injury-related death in the elderly. And since age is a risk factor for glaucoma, this can be particularly important with our glaucoma population. In fact, there's 3 times as many deaths in the elderly population from falls as from motor vehicle crashes, in contrast to, for example, patients in a younger patient population. Field loss is directly correlated with a higher risk of falling, and glaucoma patients, incidentally, are much more likely to be involved in motor vehicle crashes as well, and more likely to be at fault in those motor vehicle crashes. And falls also carry a significant psychological impact in which patients, particularly the elderly who have fallen, develop a fear of falling that can be psychologically damaging and limiting for those patients. And therefore, falling and fear of falling has become an important metric and health outcome, and one that is tied to visual field loss. If we compare measurement of the visual field and visual field loss to some of the other options that we use in terms of trying to identify glaucoma progression, the visual field may have some advantages. So, for example, sometimes when we look at the optic nerve alone, we may not get the full picture of the patient's progression. For example, if you take a patient who has very significant optic nerve damage, you might, in that context, see visual field changes before you can identify someone moving from advanced cupping to a little bit more advanced cupping. So once you get to a certain part where you're crossing that threshold into perimetric glaucoma, where there's visual field change, the visual field can be a very important part of trying to follow these patients. And also with optic nerve analyzers, studies have shown that, for example, with OCT, as the retinal nerve fiber layer, the global retinal nerve fiber layer decreases, the reliability of the machines may also decrease for helping us identify glaucoma progression. In addition, as we know well, and Dr. Spaeth mentioned at the beginning of his talk, intraocular pressure is not a surrogate for progression, and progression occurs at a wide spectrum of different pressures, from average pressures to no progression at high pressures. So moving on now to the other side of the coin and some of the limitations we face in dealing with visual fields and their use in progression. I started by saying that the visual field always conforms to characteristic patterns, which makes it useful for identifying progression, but that's really not true. There are some types of glaucoma that tend to be more aggressive and in which you may get visual field loss relatively early in the course of the disease, or you may get somewhat atypical visual field loss, particularly in low-tension glaucoma, where it's been shown that the visual field defects may in some patients be deeper, steeper, and closer to fixation than in primary open-angle glaucoma. and that dense scotomas that are close to fixation may occur with relatively low levels of total visual field loss, in contrast to, for example, primary open-angle glaucoma, where you would expect that paracentral visual field loss would occur in the patient with dense constriction and already profound peripheral vision loss. In fact, these patients with low-tension glaucoma who have paracentral visual field defects may represent even a different population, where in these people there are different risk factors, or there's something different going on. For example, paracentral field defects in low-tension glaucoma have been tied to an increased incidence of systemic hypotension, and there's a lot of interest in perfusion pressure and the effect of low blood pressure on glaucoma progression, particularly in low-tension patients. So this field is from a patient that I see, and if you look at the first test in 2006, certainly there is a suspicion here for not just a paracentral defect, but maybe an arcuate. But in 2007, on a repeat test, it's much less dramatic. There's something going on in the paracentral area, but it's underwhelming. But if you do a 10-2 to highlight that paracentral area, there really is a well-circumscribed defect that is there. And so just this simple paracentral defect in a low-tension patient can be an indicator that something much more serious is going on in their paracentral area. This is the fellow eye, which shows a defect as well that's much more dramatic and would get your attention from a glaucoma perspective, but is very close to fixation. And the 10-2 in that regard, too, is frightening. Unfortunately, though, many patients progress with glaucoma but don't have visual field changes. The pre-perimetric stage is an important stage in progression to identify and to prevent, so that patients don't ever get to the stage of functional vision loss. And as the DDLS indicates, it's really the patients who have neuroretinal rim loss completely in some area that we would expect to then have visual field change. And so there is a whole progression that occurs from very normal-looking optic nerves to optic nerves that clearly are abnormal but are still pre-perimetric, like those at the DDLS of 5 stage. That's important and would be missed if all we ever did was follow our patients with visual fields. Although the visual field test, if you look at it in relative terms, is relatively quick and easy to obtain in the office, it's also intensely disliked by our patients. And the visual field test can, or any test for that matter, that increases the burden in test time and frustration can ultimately affect how willing patients are to be followed for glaucoma, how compliant they are with their follow-up. And over the course of the long term in treating glaucoma patients, that is a very important factor. Additionally, lower motivation with the visual field test can affect the outcome of the test itself. So if the patient gets frustrated or tired when taking the test, they're unlikely to get as useful a result. Also, these tests, which measure patients in a way in which at least 50% of the test spots may be missed in a normal test, can be very frustrating. And patients get disconcerted by not seeing lights that they think they're supposed to see, and ultimately may give up on their visual field test. There was a study published where they looked at over 100 subjects with ocular hypertension and glaucoma, and they asked them to grade a bunch of clinical tests on absolutely disliking being a 0 and perfect satisfaction being a 10. And you can imagine there were no 10s. If we look at just a quick table of the survey results, amazing given the patients that are squeezers, which I'm sure we all have, intraocular pressure measurement was the favorite test. But bringing up the rear, though at the top of this particular graph, is automated perimetry and swab testing. So the least favorite test was visual field testing, beaten also by multifocal visual evoked potentials. Another limitation of visual field progression is that we don't really have a great way to measure visual field progression. And in fact, if we get some of the smartest people in glaucoma together in a room to create a guideline for identifying visual field progression for a research study, which doesn't have to abide by the same limitations of ease and efficiency we might need for our clinical practice, their systems don't overlap in a way where they get consistent agreement on all the patients who progress when we look at the study data. So a major limitation is that we can't agree on exactly what defines visual field progression. Inherently, as we all know, visual fields are a balance. The harder we try to get exact data on what a patient can see at a particular test spot, the longer it takes, the more we exhaust the patient, the more we introduce poor reliability at some point in the test when they become fatigued. And on the flip side, when we use algorithms to approximate what they're actually seeing at a particular point, we are also going to fundamentally create shortcuts that ignore some of the data and probably don't give us the same results, the ones that we really want. So we're always trying to reach some balance, and that results in noise and variability in the visual field, which affects its utility. Among the best examples of the variability in visual fields are the results of the visual field test in the ocular hypertension study. So if you look at a massive number of people who took visual fields in a test where they had really aggressive quality control measures and maintained a pretty impressive reliability rate. If you look at the tests that were retests where if someone had a visual field defect or it was an unreliable test and then they went back and took another one to follow up on that, 86% of the abnormalities that were identified on the first test were not then consistent on the second test, showing that there is a significant problem with reliability, especially in people who are naive to visual field tests. Further confusing matters, in patients that are getting moderate damage to their visual field, the variability in those locations may be even higher than it is in normal points. So the points we're most concerned about, we may be getting the most noise. And additionally, the increased variability itself may ultimately be an early indicator of glaucoma. There's some theories on why we get the increased variability as we get glaucoma damage, and they may have to do with cognitive function and decision criteria or the strategies we're using, or even neural noise where there's some physiologic reason that as the ganglion cells are damaged, they don't work as well to create a reliable indication of what's going on at that particular peripheral vision spot. Ultimately, the variability of the test means that we have to get a lot of tests before we ever can get a really clear picture of what is glaucoma progression. Different studies have provided us different information on how many tests we really have to get to be confident we have progression, but the number may be 6 to 7 tests. Which is a lot of visual field tests, especially if you figure on an average patient you might be checking a visual field once a year. That's a lot of years of checking tests before we're identifying progression, especially in light of approximations of visual field progression at certain pressures that it may occur even at pressures in the mid-20s in less time than it takes for us by the numbers of the studies to identify conclusively visual field progression. So that's certainly a limitation. In conclusion, I think we all hope that our ability to measure glaucoma progression will be better and better with time and more objective with time. There's interesting information about different markers of cell death that may ultimately help us identify progression. Dr. Katz already mentioned increased information about intraocular pressure measuring may help us better identify patient populations at risk of progression. Certainly our optic nerve analyzers, the amount of data we can acquire is growing exponentially. And measures of brain function like visual evoked potentials, we'll see if they ever reach a resurgence and become more useful. Even ocular blood flow analysis or genetic testing might ultimately help us identify at-risk patient populations. But as far as visual fields go, visual fields are certainly imperfect, but they're the best way we have to approximate peripheral vision right now. And though I expect that the technology and the algorithms we use will make visual field testing easier on us in interpretation and easier on patients, it's never going to eliminate the fundamental problems of poor reliability in this subjective test. And that forces on us the question of when you have a test where in any given test you might discount the results as being simply variability or noise, does that mean you want to get less of those tests, or do you actually want to get more of those tests to try and get a better handle on whether or not you are able to conclusively say a patient has progression? Any questions? Thank you.